Hello and welcome once again to another episode of the EAO Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heikoop and I'm the host of this channel, and in tonight's special edition of this live video session, we'll zoom in on the results of the EAO Consensus Conference 2021. And therefore, I'm now joined live from Switzerland, Zurich, by Daniel Thoma to zoom in on the work of the second group, soft tissue management. Daniel, good evening.
Good evening, Gerrit. Good evening,
good to see you as well. Welcome. And also with us live from Frankfurt, Germany is Ausra Ramanauskaite. You were the secretary of the third group that worked on the topic of peri-implantitis. Good evening, Ausra.
Hello from Frankfurt, everyone.
Yes, welcome. As always, this is a live video session. We kind of have three parts because we're covering two different topics. In the first part of this session, I'll be talking first to Daniel about soft tissue management for about 15 minutes about the key findings of the consensus conference. Then we switch to Ausra. We'll talk about the key findings and more specifically also the clinical recommendations of the group that worked on peri-implantitis. And then in the third part, we'll try to answer as many of your live questions that you are submitting. So as always, let me remind you, we are live, so make use of the fact that we're here. And I see the chat is already kind of getting started with everybody checking in from around the world. Let me traditionally make a few quick shout outs to Per Otterstad from Norway. Good to have you back, Per. We see Lawrence Swart from South Africa, Franz Joseph Strauss from Zurich, and also Leonardo Mancini from Zurich. Maria Dusman is joining us from the Algarve in Portugal. We have Berus Arafnia from Graz, and also Sunyung Ma all the way from New Zealand. So once again, a truly global crowd connecting. So make use of this live chat feature and send us any questions you might have, or just connect with friends and fellow professionals from around the world. Now, before we start, let me, if this is the first time you're joining this Just Ask session on the Consensus Conference, quickly explain what the Consensus Conference actually is. Because this is held every 3 years by the EAO. And it's used to discuss the topic of greatest importance to our professional community. And then the outcomes, these high quality scientific articles, are used as a reference point for both researchers and clinicians from around the world. And in this 2021 edition, Daniel, Ausra and I were just talking, it's almost 11 months ago now, February last year, 70 professionals came together online. They were chaired and co-chaired by Irina Seeler from Switzerland, Henning Schliephaker from Germany, and Björn Klinger from Sweden. And the 70 of them talked about 20 different questions divided into 5 topics. If you've been part of this EAO channel, you may have found the EAO Just Ask on topic number 1, timing, and topic number 4, the fabrication workflow and delivery of constructions. Tonight, we're talking about topic number 2 and 3. And there was also a 5th topic discussed. This was the special topic on COVID-19 and the European recommendations and experts' opinion. If you're curious to find all this work, you can still download it from the EAO website. But take note, this will remain available only to January 20th, 2022. I'm saying it explicitly if you're watching this in recording. So this is 3 days from now. You find the links in the description of this YouTube video below. After January 20th, the papers and the work will remain available for members of EAO. So if you're not just a member yet, or you are considering your membership renewal, this could just be one of the arguments why you should sign up. Enough context, enough of the household messages. Let's get started. Daniel, I'd like to start with you and the topic of soft tissue management. Now, before we start, besides the chair of the group that worked on this, you're also the head of the Division of Reconstructive Dentistry and also its vice chairman at the Clinic of Reconstructive Dentistry in the University of Zurich. And before we dive into the findings and the clinical recommendations, let's start with why. Why is it important to zoom in on the topic of soft tissue management tonight?
That's a very good question, Gerrit. But I would like to start and thank the EAO for the trust in having me chair group 2. I think that was an exceptional experience also for myself. Would also like to acknowledge the great work that the rapporteurs did, and also the participants or experts in our group. So at the end, I'm sharing here, I'm presenting here the data of the work of many of my colleagues. So why is the topic important? I think that's a good question. Why should include such a topic like soft tissue management? And I think I would like to shift back a little bit some years, because previously there has always been a focus on the level of hard tissue, maybe bone augmentation around dental implants. And now if you go to the literature, you find more recently quite extensive research in the field of soft tissue augmentation around dental implants. And it basically demonstrated, in some studies, some case series as well, beneficial effects, maybe on aesthetics, maybe on peri-implant health, but data were kind of inconclusive. And there was also a lot of heterogeneity. So it was really the time to collect data in a systematic manner and offer clinicians also more relevant guidelines. I think these are the reasons why this topic was included.
Exactly. Well, it's an important task, scattered data all over the place, and let's see if we can come to some specific recommendations. As we did in the Just Ask last time, let's see if we can kind of, in these first 15 minutes, scratch the surface of the key findings and takeaways of the different review articles that are the basis of the consensus report of your group. Can you talk us through that?
Yes, absolutely. Basically, you also see here presented all the 4 papers. So if I would like to summarize the papers, there were 2 papers. They were more or less straightforward systematic reviews. One is linear profilometric measurements following soft tissue augmentation in the aesthetic zone. And there is another one with the influence on marginal bone level changes. In addition, we had 2 other reviews. One was also systematic, but it was on a specific outcome measures, the so-called patient-reported outcome measures, or PROMs. And there was a 4th paper, it was a critical review, analyzing aesthetic indices and report validity and reliability. So this is just to give you a bit of an overview. Now let's dive more into these papers. I'd like to point out some of the main outcomes that we saw in these reviews. And I would like to start with the first one on linear and profilometric measurements. So that would be number 3 on your slide. Following soft tissue augmentation in the aesthetic zone by Jerry Ragobar. If we look at the review, main outcome certainly that soft tissue augmentation is beneficial in 2 ways. It first of all decreases the extent of a recession on the mid or longer term around the dental implant. And it also increases the mid-buccal mucosal thickness. And that was true for data gathered for immediately placed dental implants. When we look at delayed implant placement, then these procedures also decrease the extent of recession. So basically, whatever you choose, whether it's going to be a delayed implant placement or an immediate implant, there are beneficial effects in terms of decreasing the amount of recession. As we all know, there are different time points available when we could perform soft tissue augmentation procedures. And also based on the review, it's currently unknown whether there is an ideal time point. So this question could not be answered by that review. Mm-hmm. We had another systematic review by Stefan Fickel. It was on the influence of soft tissue augmentation procedures, now with a specific target that was marginal bone level changes. And overall, they found a limited effect of the procedures on marginal bone level changes. Just in general, data is still very heterogeneous, and it was a bit inconclusive. They found, however, other relevant or clinically relevant parameters where we could see an effect. So the extent of inflammation, but also, again, mucosal recession were improved by procedures for gain of keratinized tissue. And in addition, which kind of supplements also the paper by Jerry, there were aesthetic benefits when these procedures were performed. So in general, the main outcome was a bit inconclusive, but we did see some tendencies, and I guess when these reviews are performed in some years again, I am pretty sure that we'll find some more findings. I would like to continue. Yes,
Daniel, just
absolutely.
to zoom in on the marginal bone level a little bit. When you started with this research question, was it obvious that you were expecting effects on the bone level? Is it the fact that it's now inconclusive and you say perhaps in the future we can say, is it to be expected?
Well, the problem always is, I mean, this has never been really a primary outcome maybe in studies, because usually when we have clinical studies that document soft tissue augmentation procedures, it's usually around, well, they deal with a gain in width or gain in thickness. Yeah. And in many of these studies, margin bone level changes are not reported. So my feeling is that this is one of the reasons why the data were kind of inconclusive. But it's always good to have a systematic review, and then we know also when we run future clinical studies that certainly will include these parameters and outcome measures.
Exactly. Clear. Thanks.
You're welcome. So I would like to continue with the third one. That was the critical review on aesthetic indices by Jan Cousin. So main outcome in general, there was a good inter-rater reliability, and there were 6 main indices that have been used in the past. We see that when we look at aesthetic indices, there are basically a lot reported in the studies, but 6 of them were quite often reported. Unfortunately, there was a limited correlation between different indices, which makes it difficult also for reviews maybe in the future to compare different studies. When we look at specific outcomes like single crowns, the pink aesthetic score was the most reliable and most validated index. So whenever we run studies on single crowns, it might be very useful also in the future to use this index. And clinicians were also urged to use a validated and reliable index and not just one that has been rarely used. In addition, they also looked at outcome measures, how they were assessed, and they found that in the past or in more recent years, digital technologies have been more often used, and also urged researchers and clinicians to use these technologies.
Mm-hmm. And Daniel, if I may ask a quick clarifying question here as well. You say 6 different aesthetic score systems were identified, but there was no correlation. How should I understand that takeaway? What does it mean when the scores do not correlate?
Well, you see at the end, when you run a clinical study, you will probably choose only one index. And in the future, or whenever you run a study, you want to compare your outcomes to the outcomes maybe of my colleague, to Ausra's outcomes maybe in her study. So I think it would be very useful if we could use different indices, because they might be used more often in some places. But very unfortunately, we can't compare the outcomes because they don't really show the same outcomes. So it's strongly suggested to use standardized indices, at least in addition.
Clear, yeah.
And then maybe the fourth review, a very interesting one by Martina Stefanini on the impact of soft tissue augmentation procedures on something that is very important, and this is patient-reported outcome measures. So PROMs in general, they include patient-reported morbidity, they include patient satisfaction, they also include the perception of aesthetics, and predominantly as well oral health-related quality of life. So this is what has been reported in conjunction with soft tissue augmentation procedures and clinical studies. Very unfortunately, PROMs, usually they were not primary outcomes, and in many of the studies, they were insufficiently reported and not commonly used. So again, very heterogeneous data made it very difficult to compare, and also it was impossible to run a meta-analysis, difficult to compare these studies. So there were also some strong recommendations to researchers and clinicians that they should apply PROMs also at different time points during implant therapy and report these outcomes in detail. And maybe I can add here a little bit more, because very often we would find outcomes like patient satisfaction was high, but it wasn't mentioned what kind of, maybe should be visual analog scale, what kind of question was being asked. So I would really like to standardize these outcome measures in the future. So that was basically the summary of the 4 papers.
Exactly, a very quick high overview. And if I listen to you careful, Daniel, I hear you almost 3 times make a call, almost a scream to this global audience that are literally now joining from all over the world, that in order to kind of aggregate all the different things that are happening in different clinics around the world and also the different studies, we need to better work on how we make our results comparable. I hear you say that about the scores. I hear you say it now about the prompts. Is that one of the important takeaways kind of on a meta or researcher's level from yourself?
You see, when I started in the beginning, I said this is a relatively new topic. And whenever you have a new topic, we as clinicians and researchers aren't really aware of what we should measure. And only during time and predominantly when you run systematic reviews, you realize what you should report. So also us in the clinic, this helps a lot because we realize, okay, prompts are quite important, for example, and we would certainly use them more often and also standardize them the way we use them. So it helps us a lot in the future.
And is there, to make this practical, is there already a recommendation or maybe a personal recommendation on which patient-reported outcome is the key or should have priority, or should we start with tomorrow?
I don't think there is a key patient-reported outcome measure. It depends what kind of procedure you perform. Traditionally, when you do perform soft tissue augmentation procedures, autogenous tissue is involved, which has been reported to increase patient morbidity. So that would certainly be a good outcome measure. When we deal maybe with the aesthetic zone, and like we had the systematic review by Jerry Ragobar, then of course would include patient satisfaction, maybe with aesthetics. But certainly would urge clinicians to use prompts in general more often in the future.
Exactly, that's the general recommendation. Now, you've been involved with the EAO Consensus Conference before, also with many other consensus conferences. If you would have to say, what's the news from your group? What are the key findings which are different from the knowledge that was already out there?
Well, I'm very happy that we had a comprehensive overview on the topic, and we not only had the traditional systematic reviews, which, in my feeling, really helped me also as a clinician, but we also had 2 reviews that help researchers, the one on aesthetics, on the aesthetic indices, and also the one on prompts. They really help us as researchers. So I think what is new for me, it's really a comprehensive group, a comprehensive topic, with 3 systematic reviews and 1 critical review. So I guess makes it a little bit different.
Exactly. Nice. Well, it's definitely a good teaser to now go down in the description of this video and actually try to download the work and read. And all the papers, I've been through it this afternoon myself, are very well structured. And if you have a little bit time like myself today, you can just read the key management summaries. And if you have more time, you can go as deep as you want. So a good teaser. Thank you, Daniel. For now, let me remind our audience, especially if you're just joining us, we are live. And in the second half of this hour, we're going to try to answer as many of your questions as we can. So if you have any questions on soft tissue management, on the research, on the aesthetic scores, on anything you just heard Daniel scratch the surface on, make sure you submit your question in the live chat on YouTube, and I will relay your question to Daniel on your behalf. So Daniel, thanks for now, and see you in about 15 minutes after we've scratched the surface on the topic of peri-implantitis. Because also with us from Frankfurt, Germany, Ausra Ramanauskaite. Ausra, welcome once again.
Hello, Garrett. Hello, everyone.
Hi, you were the secretary of the group that worked and was chaired by Lisa Heitz-Maidfield and Frank Swartz. And you're here to report the work. You are a oral surgeon and periodontist yourself, and you can tell us what are implant and prosthetic factors that actually may change the course or the risk factors for peri-implantitis as well. So same question to you. In your case, there's 3 review articles supporting the consensus report. I'm very curious to learn what were the key findings from your group.
First of all, Garrett, I'm very glad to be here this evening, and thank you, the EAO, for this opportunity. And I will report, I'm very privileged to present the findings of a group 3, which focus on peri-implantitis. And our group consisted of 12 remarkable experts, and as you already mentioned, was chaired by Professor Frank Schwartz and Professor Lisa Hayes-Mayfield. So our group aimed to investigate the current evidence on how implant and prosthetic factors influence peri-implant tissue health. And the second aim of our group was to investigate or to analyze peri-implant soft tissue changes following surgical treatment of peri-implantitis. And these topics were covered by 2 systematic reviews and 1 narrative review. And I would like to start with a later one, and I will shortly address the main findings of a narrative review conducted by Professor Nikos Mateos and his working group. And this group investigated the data, analyzed the currently existing data, reporting on the correlation between various components of the implant, abutment, and prosthesis junction at the transmucosal area and the occurrence of peri-implant tissue, peri-implant diseases. So first of all, this analysis considered randomized clinical studies, prospective studies, retrospective studies, as well as cross-sectional data. And the group found limited evidence coming from cross-sectional studies that emergence angle greater than 30 degrees, along with a convex prosthesis emergence profile, increased the risk for peri-implantitis at bone-level implants. Cross-sectional data further showed increased risk for peri-implantitis in the presence of reduced prosthesis accessibility for oral hygiene procedures. And at the present, there appears to be no clinical evidence that such factors as implant type, including bone-level implants or tissue-level implants, as well as prosthesis or abutment material or surface characteristics, as well as supracrestal vertical soft tissue component height, whether those factors associates with peri-implantitis. And the evidence regarding the retention type, including screw-retained or cemented restorations, as well as design or location of implant, abutment, and prosthesis junction, and the risk for peri-implant tissue inflammation remains inconclusive. So, taken into consideration this quite limited existing clinical data, the working group came up with a clinical recommendation suggesting that in order to reduce the risk for peri-implantitis, over-contouring of a prosthesis defined by emergence angle and convexity should be avoided. And it is very important to assure a proper circumferential access for plaque removal from the prosthetic restoration. And if the shape of a prosthesis does not allow to properly perform oral hygiene procedures, it should be modified. As a concluding remark on this narrative review, and also as acknowledged by the working group, we still have to understand that majority of the available clinical studies, they had a cross-sectional design, which may not allow the accurate assessment of the actual role of a different implant and prosthetic factors at the transmucosal area of the implant upon the risk for peri-implantitis. So which means that in the future, what we need are well-designed prospective studies and randomized clinical studies with clear disease definitions to understand the role of those aforementioned factors upon the health or peri-implant tissue disease. So now, from...
Exactly. And just before we move on, Ausra, because when I listen to you carefully, I conclude design does matter, right? It's
Absolutely.
The emergence profile over 30 degrees, the convex design. I was wondering, can you say anything about the incidence of these type of designs? Do we know if these are very common or rare? What is the impact of this very clear clinical recommendation?
Yes, Garrett. So I will not go deep into the numbers, but what we need to understand is the fact that peri-implantitis is bacterial plaque-induced disease. So it means we have to do everything to assure a proper plaque maintenance. And prosthesis design is one of the local risk factors that may not allow the proper plaque control, as well as it's one of the major iatrogenic local factor.
Mm-hmm. Exactly. So that is kind of a general design factor that we should all keep an eye on, and that
Absolutely.
we can all understand regardless of the specific design. Yeah, clear.
Yes.
Clear. Thank you.
Yes. So now I would like to move on from the transmucosal implant part to the endoosseous implant part. And here I will address the main findings of a systematic review conducted by Professor Andreas Stavropoulos and his working group. And this work focused on the influence of implant material and implant surface characteristics upon the onset and progression of peri-implantitis. And first of all, here we need to understand that progression of peri-implantitis cannot be studied in humans due to obvious ethical concerns. And therefore, this analysis also included preclinical experimental in vivo data that employed a ligature-induced peri-implantitis model to understand the potential role of implant material or implant surface characteristics upon the progression of peri-implantitis. And implant surfaces were classified according to their characteristics. Non-modified surfaces refer to minimally rough surfaces, and modified surfaces refer to moderately rough and rough implant surfaces. And meta-analysis based on the experimental data pointed to significantly higher extent of radiographic bone loss, as well as a greater area of infiltrated connective tissues at the peri-implantitis lesions occurring at the implants with modified surfaces. However, if we would take a closer look into those investigations separately, we would see that still majority of the studies failed to find a difference of the extent and the progression of peri-implantitis irrespective of implant surface characteristics. And this was true for the 5 out of 8 studies reporting on the extent of radiographic bone loss, and for the 3 out of 5 studies reporting on the infiltrated connective tissue area. And now with regards to implant material, one experimental study investigated progression of peri-implantitis at zirconia and titanium implants and failed to find any difference in terms of the extent of radiographic bone loss irrespective of the implant material. So now, from the preclinical data, let's move on to the clinical setting. And majority of today available clinical studies were reported on the survival rates of the implants or radiographic marginal bone loss at the implants with modified and non-modified surfaces. And even though no meta-analysis was feasible due to heterogeneity of the data, the investigated clinical studies did not find any considerable differences in terms of either implant survival or marginal bone loss among the implants with different surface characteristics. The authors identified 3 randomized clinical studies that reported upon the incidence of peri-implantitis with clear disease definitions for the implants with modified and non-modified surfaces. And 2 out of 3 randomized clinical studies reported similar incidence of peri-implantitis irrespective of implant surface characteristics throughout 12 to up to 20 years of follow-up period. Whereas one randomized clinical study, which was based on periodontally compromised patient population that exhibited residual periodontal pockets at the time of implant placement, this analysis pointed to significantly higher incidence of peri-implantitis at implants with modified surfaces. And now finally, in terms of the implant material, the authors identified 1 randomized clinical study that reported upon the incidence of peri-implantitis at titanium and zirconia implants throughout the 5 years period and found similar incidence of the disease irrespective of implant material. So now summarizing, again, quite limited existing clinical data, the working group could not provide any particular recommendations as to which material or what surface characteristics should be preferred or vice versa should be avoided in order to reduce the risk for peri-implantitis. But the clinicians have to keep in mind very important fact that local risk factors such as poor plaque control, as well as history of periodontitis, might increase the risk for peri-implantitis to a much higher degree. So now from yes. So Gerrit,
so that is a similar recommendation and as in the first review. In the end, it's all about plaque control accessibility. Absolutely. And when I listen to you carefully, the paper states, we cannot say that surface or material matters, but we can also not yet say that it doesn't, right? Based on the studies we have now, we cannot make any distinctive conclusions. That's what I hear you say.
Exactly. Today, we do not have clinical data supporting some particular materials or some particular surfaces.
Clear.
Exactly.
The third article, what did that say?
Yes, so Garrett, now from the implant and prosthetic considerations, I would like to move on to the soft tissue considerations. And here I will refer to the systematic review and meta-analysis conducted by Ignacio Sanz Martin and his working group. And this analysis focused on peri-implant soft tissue changes following different surgical treatment approaches of peri-implantitis. And we obviously able to conduct a meta-analysis which was based on 19 investigations, including randomized clinical studies, prospective clinical studies, as well as case series studies with at least of 6 months of follow-up period. And the meta-analysis estimations clearly revealed that the extent of postoperative soft tissue recession depended upon the implemented surgical approach. And in particular, non-reconstructive approaches, including access flap surgery or resective therapy, defined by apical positioning of a flap with or without bone recontouring, so those approaches resulted in considerably higher postoperative soft tissue recession compared to reconstructive approaches. And the estimations also revealed a weighted mean difference of postoperative soft tissue recession of 1.35 millimeters in favor of reconstructive approaches compared to access flap surgery. And factors such as bone filler material or adjunctive use of a barrier membrane or adjunctively performed implantoplastic were not found to be the factors influencing the extent of postoperative soft tissue recession. As highlighted in the recommendations provided by the group, we still need to keep in mind that the main goal of peri-implantitis treatment is to obtain disease resolution. So therefore, the treatment approach should be selected based on the defect morphology rather than focusing on minimizing soft tissue recession. And for instance, presence of supracrystal defects, they may require resective therapy rather than reconstructive therapy, and therefore might possess a higher risk for peri-implant tissue recession. Whereas, for instance, in presence of intrabony defects, reconstructive therapy might be superior in terms of maintaining peri-implant soft tissue height compared to access flap surgery. And the secondary goal of this group was to investigate and to better understand the patient-reported outcomes. However, no single study could be identified reporting on the patient perception upon the postoperative soft tissue recession. And this further highlighted by the recommendations provided by the group. It is very important to inform the patient about the high risk of postoperative soft tissue recession, which might interfere or have a negative effect upon the overall aesthetic outcome of implant-supported restoration. So Garrett, those would be the main insights from the working group 3.
And thank you, Ausra, for this clear summary. Just to conclude, similar question as I asked Daniel, if you would have to say, what is the news here coming out of this group? What is the key thing that you would point at?
So now regarding the soft tissue changes, so today we have clearly data showing that reconstructive therapies might be superior compared to non-reconstructive approaches. And this we have to keep in mind, particularly whenever treating the cases in aesthetically demanding areas.
Exactly. Well, thank you for introducing us to the work. And with that, we enter the second half of this EAO Just Ask, which is all back to the core of what this format is all about. And that is Just Ask. So if you're just joining us, let me remind you, we are live, at least if you're watching this on Monday night, January 17th. If you're watching in recording, then it's a different case, which is obviously also a hint to those of you watching. You can always pick up this link and share it with anybody in your network who might find this interesting, because the recording will remain available on this EAO channel. Welcome back also on our virtual stage, Daniel Thoma, talking to us about the work on soft tissue management. And we have the first few questions coming in from our global audience joining. So let's see. I'll just pitch questions to you, reading them off from the chat, and let's see how far we can get. First one came in right after you were done, Daniel. It came from Alfonso Gil. Starts with a good compliment, great summary, thank you very much. But his question is, you mentioned a little bit on the effects of timing on the outcomes of the soft tissue gain. But his question is, how important is the timing for the management of a soft tissue complication around implants? Is there any data, knowledge, or anything in the work of this group that could answer that for Alfonso?
Yeah, that's a very good question from Alfonso. I think here we really were talking about the normal ideal cases. And of course, we perform these procedures very often, as we have heard from Ausra as well, when we have peri-implantitis, but we often treat cases, treat complications. There might just be soft tissue complications. Usually the recommendation always is that we always carefully address the implant site during implant therapy at various time points and check whether or not a soft tissue augmentation procedure would be necessary. Ideally, it's always done prior to the insertion of the final restoration. Everything else done after the insertion of the final restoration complicates the procedure. It's probably less predictable. So ideally, it's done before.
Exactly. That makes sense. And I guess only in the case when you deal with complications, that's not possible anymore. But if you have a proper treatment plan and planning, that's where you do it.
Well, you see, just if I may add, I mean, you could also have a complication during therapy before you finalize the case. So True. It's always good that we address or at least check the soft tissue condition at various stages. And the earlier we do the procedure, if necessary, it's more predictable.
Yeah. Alfonso is live with us. He says, thanks, Daniel. Perfectly clear. So point for us. Ausra, question for you as well. Alexis Ionanidis is writing, thanks Ausra and Daniel both for these helpful summaries. He's wondering, we talked about design matters, and his specific question is, what about the influence of the implant design on the perihembatitis risk or the progression of the disease? Is there anything else you can add to that?
Mm-hmm. So as I already mentioned before, that implant design, so I think that Alexis had in mind bone level implants or tissue level implants. So we do not have solid data showing or pointing to one specific design that the bone level implants or tissue level implants possess a higher risk for perimplantitis. We have cross-sectional data suggesting that tissue level implants might possess a lower risk for perimplantitis, but again, at the end, when we summarize all that we have today, I cannot come up with any solid conclusion.
Exactly. So based on the work that there's now, we cannot be straightforward on answering that. And I think that's an important message coming out of this group. There's some new clarifications, but yet also so many unknowns in this field. Yeah. Daniel, question for you from Franz Joseph Strauss. Your call for better study design, standardization, and including the PROMs, the patient-reported outcome measures, has been echoing. I felt it as well. That's why I also clarified and tried to make that practical. He's on the same path. He's wondering, is there any ideal time point for the measurement of PROMs following soft tissue augmentation? So I asked you, is there something specific we should measure? He's wondering, is there any specific timing for that?
Yes, that's certainly quite important. You know, you asked me before, what are PROMs? And then I answered you, you know, there are different ones. You know, you could assess aesthetics. Obviously, when you assess aesthetics, it should be done at the end of the treatment. Mm-hmm. If you're assessing morbidity, like when you do a surgical procedure, you want to know whether patients have pain, it's highly important that you do it during the first 7 to 10 days. So it doesn't make sense to ask the patients 1 year later or 10 years later because they can't even remember it. So the time point is very important. And I think we have some good studies that have used in the PROMs in the last maybe 3 years, and they have used it at ideal time points. So it's certainly always a recommendation that we check other clinical studies that are published in high-ranking journals and check what kind of time points they chose. But it's an important issue, yes.
Yeah, and while you say that, I'm also thinking, and that's almost, I guess, philosophical, but could it matter that maybe during the treatment, I evaluate the morbidity or the pain as very high, and it's a very cumbersome procedure. But then later, when I see the aesthetic results, I forget about the pain, right? I guess some of these patient-related outcome measures are related, right, or relative to each other.
Yes, yeah, that's a very good conclusion. And actually, you know, there are some standardized questionnaires like the Oral Health Impact Profile, where you also assess morbidity, for example. So quite interestingly, these questionnaires are handed out to patients at several time points. And you will see high morbidity or high values post-surgical treatment. And then if you hand out these questionnaires, maybe a year or 2 years later, the numbers drop like they were before treatment. So it actually also shows that patients forget. Of course, aesthetics may matter, but they are not covered by such a standardized questionnaire.
Okay, clear. Now, another audience question coming in, of which I'm not sure if I completely understand what the question is, but let's try. It comes from Firas Kiki, joining us from Russia. Question for Daniel. What are the 3 points that you take when it comes to extract or survival of the implant? So I think he or she would like to know, how do you consider whether you move on, in this case, with soft tissue management or augmentation, or when to decide that an extraction might be the better option?
Not really sure if I got the question right. So maybe it's about whether or not to do a soft tissue augmentation. Maybe that would be a good question. Basically, there are 2 procedures during regular implant therapy. So either you gain keratinized tissue, so you want to improve the tissue quality, or you want to increase the mucosal thickness. And increasing the mucosal thickness predominantly is being done in the aesthetic zone. And we also heard before that it prevents some recession, or at least less recession. Whether when we move to the predominantly the mandible posterior zone, there it's quite important to have sufficient keratinized tissue. And I think also Ausra mentioned that, because we want our patients be able to clean restorations, and without a sufficient amount of keratinized tissue makes it very difficult. So plaque might accumulate, and this could result in a mucositis or even peri-implantitis. So exactly. I think these are the indications for the procedures.
Exactly. And Firas Kiki replies, it's a he from Russia. And I think this is a question. And if not, feel free to reach out also to Daniel one-on-one, I guess.
Yes, I'm happy to answer.
Exactly. Nada Zazu is pitching a question for you, Ausra. But we stay on the topic of keratinized tissue, but then in the different context. Now back to the context of peri-implantitis. The question reads, you mentioned there was no evidence related to soft tissue height. How about the amount of keratinized tissue around the implant? Do we have any conclusive data on that?
Yes, thank you very much for a very good question. So in recent years, there have been many discussions. So do we need keratinized mucosa at dental implants to maintain peri-implant tissue health? And I think today we have enough data showing that, yes, we need keratinized mucosa to maintain peri-implant tissue health. And we have clinical studies showing that implant sites showing less than 2 millimeters of keratinized mucosa or absence of keratinized mucosa are more prone to develop inflammatory diseases. Also, we have data showing that those sites that were augmented using substitute materials or autogenous tissues, those sites showed significantly lower plaque accumulation, low building scores, and stable marginal bone levels compared to untreated sites. So definitely, yes, we need keratinized mucosa at implant sites.
Exactly. We need that, and it decreases the risk for peri-implantitis. That's what you say.
Absolutely.
Okay. Next question coming in. We're on the breach. Question comes in and we're right there on the timing. Per Ottestad from Norway is also pitching in a question regarding surgical technique. Do submarginal inaction reduce the soft tissue recession to adjacent teeth compared to marginal or sulcular incisions? Do you feel comfortable to say anything about that, Daniel or Ausra?
I think, Ausra, do you want to answer the question?
No, I was not sure. Is it? Yes, I was not sure it was regarding the peri-implantitis surgery, but probably soft tissue surgery. Yeah. So maybe I will pass it to Daniel.
Okay. Well, I mean, we have seen in the past many different techniques. And I think it's not so important that we know many different techniques. At the end, we should feel comfortable in doing, let's say, if you want to increase the thickness of the mucosa, you should perform one single procedure all the time. I think then we feel confident and probably get the better outcome. And I'm not so sure whether there's an ideal or better technique, even though it has been described by many clinicians that you should do it that way or the other way around. But my feeling always is the technique should be kind of simple, so everyone should be able to do it.
Exactly. And if I read, well, because it was so live, I didn't have a chance to pre-read Per's question. But when I read it again carefully, his specific question is, do submarginal inaction reduce the soft tissue recession to the adjacent teeth? Do we...
I'm not really sure what the question is. I don't feel comfortable with... I can't read it, so
it's too specific. Yeah, too specific. Sorry, Per. Maybe you.
But he can write me an email, and we can have a conversation.
Exactly. We try to stay as live as well. It's interesting that both of you work on the topic of the soft tissue management, but Daniel, it seems you more from the primary outcome, the aesthetics, the tissue and volume, and obviously Ausra, you're more from the peri-implantitis and preventing complications down the road. I'd like to kind of see if I connect these two worlds. Daniel, if you listen to the outcomes of Ausra's group, is there anything that sticks to mind or a question that pops up in your mind?
A question. Well, you see, what we present is not always what we do in the clinic. And I'm very happy that there is so much research coming from this group on the treatment of peri-implantitis, because this is a disease we see very often in the clinic. And I have patients that I treated by myself that develop these diseases. And I think it's, for me also, what you summarized, Ausra, is that the key issue currently, I feel, is the prosthetic reconstructions, because in the past, we have not really looked at the reconstructions. The issue was always the marginal bone level, but now you're looking at different factors. And I think also scientifically, this is highly interesting.
Yeah, so that's where you say the news is. Yeah, that's where you find the new information and also the new research field for the future. Yeah. In the meantime, this bought us enough time to get a new audience question in. So let me read B. Kansu's question. What do you think about when you encounter bowl-shaped defects around the implant? Could it be completely occur with excessive occlusal trauma, or how can we detect it correctly? That's the question, Reed. Mm-hmm. Is that clear?
So I think that it was referred to peri-implantitis lesions that we find in a daily clinical practice. So if we would take a look into classifications that was first of all introduced a couple of years ago, we would see that the defects that we most frequently find are circumpharyngeal defects in peri-implantitis lesions. So this is a typical morphology of peri-implantitis defects, and those defects are favorable in that way that those are defects where we can perform reconstructive therapy.
Exactly. And the second part of the question, how can we detect correctly that we are dealing with such a bowl-shaped defect?
Okay. So for the diagnosis of peri-implantitis, most frequently we use two-dimensional radiographs. So we have a panoramic radiograph or an apical radiograph. And based on the two-dimensional radiographs, unfortunately, we cannot exactly say is what defect will we find whenever we will open the flap. We can just anticipate the configuration of a defect, but we have to inform the patient about the possible treatment approaches depending on what defect configuration, that we will make a final decision intraoperatively whenever we open the flap. Because based on a two-dimensional radiograph that are frequently used, it is very hard to anticipate.
Exactly. So we have to have a broader perspective there. That is something that I also found in the consensus report of the soft tissue management group. Daniel, it was writing about how to measure and how to best monitor soft tissue, either recessions or modifications. And then I read something about the importance of digital scans. Can you elaborate a little bit on that?
Yes, there was one review by Jan Cousin that really pointed out that these digital technologies should be used more often because they found that in recent papers, these have been used, and there are also studies that basically compare traditional measurement methods to digital ones. And obviously, according to that review, there are some advantages of using these technologies. And I mean, this is not something new. We take digital impressions, for example, since 3 decades. And so this is something we do on a daily basis, but this obviously can also use now to do some measurements. So it's a recommendation to use, for example, scans for measurements of soft tissue.
Specifically for the soft tissue measurements and the development over time. Eh? Yeah, interesting takeaway. All right, we're nearing the final minutes of this Just Ask on the outcomes of the consensus conference, specifically on soft tissue management and peri-implantitis. Obviously, I can imagine when you do such work on a consensus conference, you always look back in time, right? Because you look at all the data, at all the studies, and you try to aggregate. In this final minutes, if you look forward, what each of these papers also conclude with clinical recommendations and advice for researchers. Can you underline either one or two of the key research advices or future needed research that you would like to highlight on this global stage here today?
You want to start, Ausra? Or?
Yes, of course. So whenever we talk about peri-implant soft tissue changes following surgical treatment of peri-implantitis, what we need to know in the future is the treatment approach, which is the best or superior to ours in order to obtain disease resolution and to minimize the soft tissue recession, which is a combination, because the combination of both outcomes defines the success of peri-implantitis therapy. And also to clarify to what extent the soft tissue augmentation procedures might be beneficial in terms of maintenance of peri-implant soft tissue height. So those are the questions that should be answered in the future.
Exactly. Very clear agenda that we all should start to work on. Daniel, if you look at the future of soft tissue management research, you've mentioned some very strong points already, but what would you like to underline?
Well, I guess for clinicians, they should really carefully assess the soft tissue condition. We had that also in a question before at the implant site during the entire therapy, but also thereafter. And we also heard that digital technologies such as scans are very useful because we can monitor changes of the soft tissues in an easy way. And they don't take up space. Maybe just a little bit on a hard drive, so you don't have to store a model. And then maybe for researchers, of course, they should apply these digital technologies. It would allow us also in the future maybe to compare data of more studies. And I think we repeated it a few times. The assessment of PROMs in a standardized way is of high importance. So that's really the key messages for researchers.
Exactly, and I think that's an echo that we could also hear in the consensus conference, Just Ask Part 1, which we had last month, where we also heard this strong call. Let's please make sure that when we report on, even on the case level, but on clinical studies, on researchers, make sure that your data is shareable, is standardized, and can be used in an aggregated way in the future. While we are almost kind of getting into a conclusive moment, I now see some extra questions coming in, and since I have 5 minutes on my clock, I might actually reopen the Q&A on peri-implantitis. Ausra, this one is coming from you. Dukukan Yilmaz is writing, thank you for the wonderful summary. What is the importance of the time intervals and steps of the supportive peri-implant therapy? Can you make any comment on that?
Okay, so it is of a huge importance following the surgical treatment of peri-implantitis or to enroll the patients into a supportive therapy to prevent the reoccurrence of the disease. And I'm not sure if the question was referring post-surgical supportive therapy or in general the supportive therapy.
It reads in general, peri-implantitis supportive
So all
therapy.
of the patients that have dental implant supporting restorations, we need to include them in a maintenance program. And it is important to individualize the intensity of a maintenance appointment, since, for instance, someone who is a smoker or has a history of periodontitis would indeed need more frequent recall appointments. So what we see now also in a literature, the recommendation 6 months, 4 to 6 months is the minimal recall interval. And as I mentioned, it might be also individualized for every single patient.
Exactly, but there's a clear minimal of 4 to 6 months.
4 to 6 months is a standard according to the current recommendations.
Exactly. Well, Daniel, before I go to the last question to you, Urs Brodbeck is also referring to Ausra's background as a periodontist. He's writing, Ausra, in periodontists, we have a clear data to be successful in the treatment. What is in your opinion, the main reason we do not have such a successful treatment concepts in the therapy of peri-implantitis? What is the difference? How come we're still in the dark here?
Yeah, it's a very good question. I think here we should come back to the anatomy and morphology of the tissue. So tooth is not the same as the implant and vice versa. So we should not forget that we have not the same anatomical situation, which becomes at the end quite challenging.
Exactly. And I guess the fact that we're dealing with a foreign body also then introduces a whole lot of complicating factors that many of which we not understand exactly even yet. Yeah, now I'm answering the question for you. Daniel, last question from Franz Joseph Strauss for you. What is your advice for deciding when to use an autogenous soft tissue graft or soft tissue substitute at the implant site? And I think we should distinguish between your personal advice or opinion or what was referred to that in the work of the consensus conference group.
Yes, since we're here talking about the consensus workshop, I think I'm not reporting my personal opinion. So in the consensus report and also in the paper, especially by the one by Stefanini, there were many studies where soft tissue substitutes were used. But again, data were very heterogeneous and difficult to compare. So my feeling is, again, if we have a recommendation that prompts are used in a standardized way and more often in the future, it will probably allow us to see some beneficial effects in terms of maybe patient morbidity between soft tissue substitutes and autogenous tissue. But that hasn't been shown in the papers. And there was insufficient data for many of the other outcomes we looked at in the systematic reviews.
Yeah, so to that sense, it's kind of similar to some more of these statements that we read. We cannot say it is, but we also cannot say it isn't, right? We need more data.
But of course, we have a feeling, and we're a clinician, and we treat patients. We, of course, ask our patients as well.
Exactly. Clear. Well, Thank you to my experts and all the professionals and researchers that you represent here tonight for the great work that you all did on the Consensus Conference and the great outcome. Let me remind you once again, if you just join us, you can still access the Consensus report of the 6th EAO Consensus Conference for 3 more days until January 20th for free at the website of the EAO. If you go down on YouTube, in the description, you find the direct link. After January 20th, the work will remain available for EAO members. So if you're not yet a member, maybe you should sign up. And if you're asked for renewal, and that campaign is starting next week, maybe this is one of the key reasons why you should definitely sign that up. If you want to be part of these free educational sessions every month, make sure you hit subscribe on this YouTube channel, because you'll be the first to know when a new video is published or when a new Just Asked is scheduled. And the next one will be in a month's time, February 14th. I think that's Valentine's Day. Let's have a date together here on the next EAO Just Ask, and the topic will soon be announced. So hit subscribe on the EAO YouTube channel, the channel here, and you'll be the first to know. And if you haven't seen it, please check out the other EAO Just Ask on the Consensus Conference, which was recorded last month and which you can find here as well. Ausra, Daniel, thank you very much for your contributions tonight.
Thank you very much. It was a great pleasure.
Thank you.
Exactly. And we look forward to see you again, either in person or online at one of the future online or physical events of the EAO. Thank you so much tonight, and see you next time.
Thank you.